conversation on the first day to service. He's got that Bill Esteb chart up there that shows the phases of care and how you go through that. Hopefully everybody's got something similar to that. And because of that, he starts talking about maintenance care. We got to get your spine stable, get to the point where we can put you on maintenance care. And along the way, as you start using that word maintenance or supportive care, whichever you feel is more appropriate for the patient, then again, by the time you get to the end of that active treatment, they're expecting to go on some kind of supportive or maintenance care plan. And this thing, as they say, some will, some won't. So what? A lot of them will. And you continue to build up your practice. So what would be an unfortunate thing is you practice for 20 or 30 years, and after 20 or 30 years, you're still having to go out and do spinal screenings to get new patients to come into your office so you can continue to have a full, busy practice. What you want to get is to the point where new patients, while they're still always important, your cash practice has now risen to a point where you're financially more secure, but even more importantly, you're helping people with lifelong health-related issues through chiropractic. I love going to practice. I absolutely love going into the office. And so it pains me when I hear doctors saying, yeah, geez, I want to get out of this. I'm so sick and tired of insurances and dealing with patients and all that stuff. You know, that's unfortunate. So again, part of the reason we do this is obviously we want you to do it right, but we want to talk about the efficiencies of it. And then can you believe in it? H&S is wanting me to talk to you about how to take patients out of their system and grow your practice to another level through maintenance care. So it's fantastic. One other question that I want to have answered, and I thought it would be best for y'all to answer, is with regards to orthotics and when they need to, patients that are on orthotics and the orthotics break down, they need to have new orthotics. So they're under maintenance care, but they're due for a replacement orthotic. How would you like us to handle that?
If you look on on our website, the Blue Cross corporate medical policy for orthotics is there, and it gives it explains that they will pay for the replacement of orthotics after the normal lifespan. So that's still in existence. Okay. That still exists, but you need to do an examination. So they're on maintenance. They've had orthotics for a year, and now their orthotics are worn out. Mm-hmm. What you said, the doctor needs to do an examination, and he needs to rescan them, assuming we have a foot levels, and have exactly the same thing he did the first time. Right. But we want to indicate so that we want to establish that there is still a clinical need, medical necessity, and of course the documentation needs to refer to a year ago when they were first prescribed or whatever, and that they're worn out.
Very good. Very good. Good, Doc? Good. All right. Thank you. All right. Oh, by the way, you get paid to do all that too. All right? You get to be able to bill that into Blue Cross Blue Shield or whoever you're doing that with and provide that service. So again, you get paid for time, services, and your expertise. All right? That's great. So let's kind of move through some more things. Oh my goodness, we're doing really well here. Let's go through this. Detection and prevention of more serious health issues. As doctors of chiropractic, we received extensive training on identifying conditions in patients, which enables us to recognize problems. Further, we see our patients on a more routine basis than most healthcare providers. Is that not the truth? Especially, if you've got a big maintenance patients practice. You see these patients once a month or once every 2 or 3 weeks for years and years. So you need to pay a little bit more close attention. So chiropractors have the unique opportunity to consistently monitor their overall health and identity, identify small changes that may be indicative of a larger issue. And of course, many conditions are far easier to treat when they are identified earlier. So, there are lots of different things that we're looking for. So as chiropractors, we know that cancer often gives no signs or symptoms that exclusively indicate the disease is present. And many complaints for cancer also can be explained by a relatively harmless condition. There are, however, 7 symptoms that should elevate our suspicion of the possibility of cancer. Number 1, persistent cough over 1 month or blood-tinged saliva, blood in the stool or any change in bowel habits, unexplained weight loss, fever or night sweats, non-healing sores, change in urinary habits or blood in urine, and obvious changes to a wart or a mole, and persistent lumps, especially in the breast or testicles. So, your patients are coming in giving you that information, you're watching them. Don't you find that from the moment the patient stands up out of the chair to come in to see you, or they're in your treatment room, they go to stand up, clinically you're starting to kind of start the clock with them, visualizing how they move and do things? So some of these things may be more indicative of, you'll see that change. Most problems that present in chiropractic offices today are biomechanical in nature and do not necessarily signify a dangerous underlying abnormality. However, as we know, some pain indicates a serious condition such as inflammatory disease, fracture, referred pain, infection, or cancer to determine whether it's a potentially dangerous cause of pain. Clinicians often seek historical or examination findings that might be flags. So there are red flags and yellow flags. Red flags are clinical symptom or sign that may indicate serious pathology as a source of the patient's spinal pain. This may represent a contraindication to treatment, whereas yellow flags are a symptom or a sign that should raise the index of suspicion and regard the development of chronicity in the patient's spinal pain. So red flags. Spinal pain of unknown origin in a patient less than 20 or greater than 50. How many of you read the latest NCMIC newsletter of the young woman that had this recurrent spinal condition? It's a perfect example of that, very interesting. Trauma related to pain, history of cancer, night pain, fever, chills, night sweats, nausea, vomiting, fatigue, diarrhea, weight loss, pain at rest, corticosteroid use. That's a big one. A lot of folks on chronic utilization of steroids. Recent infection, generalized systemic disease like diabetes, failure of 4 weeks of conservative care, cauda equina syndrome, saddle anesthesia, sphincter disturbance, and motor weakness in the lower limbs. Those are things, and many of those you see in your office. Yellow flags would be superficial tightness or tenderness to light pinch. I would not suggest that you pinch your patients. Okay, we'll get into sexual boundaries here in a minute, but we'll move on. Non-anatomic tenderness, which is not localized and often extends from the lumbar spine to thoracic or pelvis. Axial loading pain when low back pain is reported with vertical loading to the patient's head. Pain with the whole body rotation when shoulders and pelvis are rotated on the same plane. Discrepancy between seated and lying SLR. And giveaway or cogwheel weakness that cannot be explained on a localized neurological basis. Sensory disturbances in a stocking rather than a dermatomal pattern of distribution, and disproportionate vertebralization and facial expressions during exam. Those are yellow flags. So, VAD. NCMIC estimates the occurrence of serious arterial syndromes to be less than 1 in 2 million to 1 in 3.8 to 5.8 million cervical manipulations. The physician must be able to recognize the signs and symptoms of VAD, and the patient will characteristically complain, "I have pain in my head or my neck, unlike anything I have ever had before." This will not present as a typical headache. A lot of times they will point right to that spot. It's right there. It's that one spot. If the patient presents with an atypical headache, the physician must first rule out vertebral artery dissection. In a review with the patient as to the signs and symptoms of VAD must be documented. The 5 Ds and 3 Ns are as follows: dizziness, vertigo, giddiness, lightheadedness, drop attacks or loss of consciousness, diplopia, dysarthria, dysphagia, and ataxia of gait, ataxia of the extremities, or falling to one side. I've seen a few of my colleagues in that state before. Nausea with possible vomiting, numbness on one side of the face and or body, and nystagmus. Okay? So H&S provides a risk evaluation form to assist us in evaluating the risk of vertebral artery dissection, and this is on the website. I have an interesting story case about this issue right now that I just told folks down in Charlotte. You'll have to listen to it a second time. So I have actually my personal physician, a friend of mine for many, many years, get a call from his office. They're referring a patient over. This gentleman's coming over. He's been under chiropractic care for a very long time with another chiropractor in Winston-Salem and was very satisfied with the treatment. So as a result of that, at one point he referred his wife over, and this is all within the last 6 months, by the way. So he sends his wife over there. She's having headaches, and he thought that chiropractors work on the headache, right? So she goes in there. Doctor does everything the right way, does the exam, does the X-rays, goes in to make the first treatment. The patient passes out, and then gets an incredibly intense headache. All right? Calls the husband comes pick her up, they take her home, so just having some kind of reaction to the adjustment, and the doctor had crossed all the T's and dotted all the I's. Get home. Well, just so happens, my friend physician is the next door neighbor to this couple, and so the husband calls up, explains what's going on with his wife, and fortunately, the physician, the internist said, call 911, I think she's having a stroke or something to that effect. Sure enough, 911, they get her medicated, they get her taken care of, and fortunately, the end of that part of the story is that she is fine. So they have stabilized her and taken care of that, and there are no permanent damage. So, first of all is finding out what the risks are, and maybe they present like that, but then having a response like that after an adjustment, you've got to know how to manage that. So interestingly enough, now the husband is at my office, which is exactly what I want, right? Is somebody that's been through this. So Dr. Sides was not in his office, so I couldn't refer the patient to him. So I had to take the patient on. So, but no, in all seriousness, so the husband comes in, he said, hey, listen, explains the whole story. I just want to resume my maintenance care. I did my thing, I did my exam, did everything, determined, yep, he was stable. We're going to put him on maintenance. So we charged for that first visit, by the way. And then he signed the waiver, and we put him on maintenance care. So he was only billed for one service. That's just a little side note for that. So anyways, the interesting thing, so he's telling me this story, and I said, well, that's fantastic. Dr. Chris took care of that, yada, yada, yada. And then he said, but we're not going to don't worry, we're not going to sue this doctor for anything. And I said, well, that was good to care. I wasn't going to get in a discussion about it. And he said, and by the way, I work for an insurance company. I do medical malpractice for the insurance company. He's an adjuster that specializes in that area. So note to self, find out what the spouse does and send them down to Dr. Side's office before you start treating them. But it was just, there's actually a lot of good things about it. Obviously, most importantly, the patient was not seriously harmed, number one. Number two is, here's a guy that has every reason not to continue under chiropractic care for risk, but he wants to be under maintenance care. That said, he never wants me to adjust his cervical spine. But that's okay. So the risk is there, right? And so make sure you're being careful and considerate with your patients. I will tell you the other thing. My very first outpatient as a clinic intern, my first adjustment, my patient passed out on me. I thought I killed my very first patient I ever saw at chiropractic school. So she comes to, and of course I'm white as pale as a ghost, and she says, does that happen very often? And me being cool as a cucumber, From time to time that happens. Don't worry, we'll just have you lie down. So, and I went out and passed out in the hallway, but oh my goodness, I thought it was over before it began. All right, medical malpractice is an unfortunate reality of practicing medicine in the current healthcare environment. Unfortunately, no one can promise immunity from lawsuits. However, keeping patients safely at the forefront of your practice, maintaining clinical competence, developing excellent relationships with your patients. By the way, that doctor did a great job with that patient after the fact. Assuring effective communication with patients, colleagues, and other members of the care team, and consistently producing accurate and legible charts that tell the whole story can go a long way towards reducing malpractice risk. So the 4 C's of risk management: competence, charting, communication, and compassion. Competence. The best defense against a malpractice claim is to be a good clinician. So we've been talking about that all day. Looking at your forms, figuring out medical necessity, making good clinical judgments. And being a good clinician means a commitment to lifelong learning. Competence. Make sure you understand and follow standards of care and state board practice guidelines and H&S clinical quality documentation standards. Standard of care is defined as the course of action that a reasonably prudent physician in the defendant's specialty would have taken under the same or similar circumstances. Plaintiff attorneys will measure your care to that standard. Number 2, charting. A physician's written documentation serves as evidence of the physician's involvement and thought process regarding the patient's care. The healthcare record provides the basis for legal testimony regarding the patient's illness, injury, treatment, and response to treatment. And written documentation supports the physician's findings, recommendations, orders, and plans concerning patient care as well. Omissions, illegible, or incomplete records leaves physicians open to lawsuits. So excellence in documentation reflects and promotes excellence in chiropractic care. Problems with documentation can make nearly 40% of malpractices difficult to defend. And never alter your record. Resist the urge to clarify the record after you've been served with a lawsuit. Emphasis on that. Again, if you have a certified electronic health record system, as soon as you open that note back up, there's a time stamp on that. So that happens. Revise your view of documentation from a necessary chore to an opportunity to clearly establish the excellent care you provide. That's why I want you to be efficient with it. I want you to take the time to organize your EHRs, your ChiroTouch, whatever your EHR is not as good until you actually organize it and can use it properly. Communication. Be honest and open, yet discreet with all oral and written communications. Effective communication between the provider and the patient is one of the best defenses against medical malpractice. How many of you call your patients after the first adjustment? Okay, about a third of us. Let me suggest, docs and staff, if my staff didn't write the names and numbers, I'd never do it. But at the end of the day, one of the last things Gabby does the first things Gabby does after the first patient or the last patient leaves, she walks in, she hands me my call list, and I call anybody that I've adjusted for the first time on that day. Hey, this is Dr. Sharp. Just want to check on you, see how you're doing after your first adjustment earlier today. Do you have any questions, any concerns? Most of the time I get their voicemail. It really doesn't matter. You're communicating with the patients. It's nice to talk to the patients, but when I go to the voicemail, I would say, I'm so sorry I missed you. I wanted to check on you and see how you're doing, see if you have any questions or concerns. I'll see you at the office tomorrow. It goes a long ways, doesn't it? Yeah, very easy. And you know what? That's free marketing, by the way. It doesn't cost a penny. The other side of that is if there is a problem, that gives you an opportunity to kind of walk the patient through that too. Trust your instincts and communicate concerns. And this is an important one. Speak ill of your colleagues at your own peril, and speak ill of patients at your peril. Resist the temptation to pepper the chart describing your patient as hysterical, histrionic, or crazy, although we want to do that sometimes. If you're wrong, you could pay dearly. Even if you're right, you may pay dearly. Keep it professional. And red flag, patients who badmouth their previous doctors, you want to avoid that. I've got patients, they've seen me, they've seen Rick Erickson, they've seen Dr. Sides, they've probably seen Dr. Work, and they kind of go back and forth, and none of us have gotten it right. You know, you want to enter into that patient-doctor relationship very carefully. Number 4, compassion. Displaying compassion for your patients and their families builds trust and strengthens relationships, both factors that can minimize malpractice risk. Studies have shown that patients who like their healthcare provider are less likely to sue, even if there is a true act of malpractice. Amazing. Do you have a patient who's not paid their bill? When patients don't pay, it may be a signal that they are having significant financial problems or that they were not happy with their care. It's surprising how often the reason patients aren't paying is because they are dissatisfied with their care or angry. Angry about the way the provider or CA acted or something that was said. Take advantage of these risk management opportunities by listening and displaying compassion. Patients appreciate the chance to discuss their concerns or issues. Okay? I'm going to say one other little thing is doctors, let your staff teach them how to manage patients, the finances of the patients, do the administrative functions of the patients. You manage the clinical functions of the patients, but have good communication between you and your staff. Your staff can say things to a patient on the phone that is just not helpful and creates environments that are unhealthy for your practice. So that's a good thing. It's a good Monday morning conversation with your staff as well. All right. Speaking of which, staff involvement. 5 ways your staff can help you reduce practice risk. As a doctor of chiropractic, you're the one providing the direct patient care, so it's easy to underestimate your employee's potential influence on whether a patient decides to sue you. But consider this. In many offices, your staff will have more contact with patients than you. Patients will consider your employee's actions, good or bad, to be a direct reflection on you and your practice. And in extreme cases, if a patient is dissatisfied with the people who work for you, it may lead to a lawsuit or at least a patient looking for another doctor. How many of you look at your Google reviews online and see what your patients are saying about you? I love it when they start talking about how wonderful my staff is, and they kind of mention me at then, oh, and he's not so bad either. But it's a good reflection on their presence in the office. So why the staff's actions may put you at risk. From a risk management standpoint, as long as your employees are under your supervision, what they do and say will be your responsibility. The reason for this accountability is the legal doctrine of repetent superior, which in essence means let the master answer for the actions of the employee performed in the course of employment. Appropriate training in the following areas and adherence to an office procedures manual can certainly help as well. Having your staff go through the compliance training that we just all had to go through, make sure they're watching that or going through that process and then ask questions. We went through the compliance training, and then in our staff meeting, I had highlighted, probably 6 or 7 different things specifically that I wanted to talk to my staff about, and most of it was patient communication, patient privacy stuff, and so that was a good thing to do. It's a great way to have a quick staff meeting. Train your staff about the way you wish them to interact with the patients and handle phone calls. Since your receptionist is the first person your patients will encounter, he or she will need to convey warmth. At the same time, your staff should maintain a professional demeanor, refraining from over-familiarity that can convey a false sense of trust and expectations. And make sure your staff members take messages thoroughly and communicate these to you promptly. Very important. Also, if you use an answering machine, make sure your staff transcribes answering machine messages in detail, including the date, time, and symptoms mentioned in the phone call, and documents this in the records. Educate your staff to involve you at the first sign of a disgruntled patient. Review with staff the early warning signs of a lawsuit, patients who make remarks in confidence to staff or don't show up for appointments. Make sure your staff members notify you immediately if a patient indicates dissatisfaction with the care and advice or cost of chiropractic care. So how does your staff communicate that to you? We have a little messaging system in our office through our EHR. We can message back and forth. Gabby will put in, she's putting somebody on. Patient doesn't think laser is helping, okay? Patient is feeling worse today. Patient took a fall today. I get little things like that throughout the day that she just sends up to me. And that kind of clues me in. It gives me an opportunity to engage the patient in conversation about things. Number 4, remind staff to follow confidentiality rules at all times. Staff should not discuss any aspect of the patient, whether it be the patient's health history, treatment, billing, or other issues, within earshot of another patient or when talking about work when at home. In addition, charts or files must not be placed where patients could inadvertently see them. Due to changing HIPAA rules, even the most careful of practices may inadvertently violate patient confidentiality, so frequent reminders in this regard can or should be very helpful. Okay? And number 5, make sure your staff does not offer healthcare advice. When your patient calls up, should I take Advil? Should I take Tylenol? What should I do? Make sure your staff knows how to answer that question. If a patient begins to describe his or her symptoms when a staff member escorts him or her to the exam room, the staff should respond with, I know the doctor will want to talk with you about that. Also, if a patient calls with a potentially emergent situation and cannot wait for your attention, as in the scenario described earlier, he or she should be advised to wait on the telephone while you are summoned. So my staff knows if they need me, they can always come up. I hate to hear that because that means trouble when I'm in with the patient. So, but they need to know the rules and when and what to do if they need to get you. All right, make sure your staff is doing their part to keep your patient safe and satisfied with the practice, and you can be confident your patients are receiving the best of care while you minimize the risk of malpractice allegation.